Hello, everyone, and welcome to our module on high-yield EKGs. So many times students come up to me and say, Dr. Ryan, I'm not good at reading EKGs. Can you teach me to be good at reading EKGs? And unfortunately, I really can't. And that's because the only way to get good at reading EKGs is to look at them every day on patients you're managing and use the things that you see on the EKG to make decisions about patient care. And that's not going to happen until you get into residency or fellowship or beyond. So as a medical student, when you only see EKGs once in a while, you can only be so good at it. What I'm going to do in this video is I'm going to give you some simple steps you can follow to interpret an EKG. And then we're also going to look at these 9 EKGs on the screen, which are sort of classic EKG findings that I think you should be able to recognize as a medical student. So if you enter into your clinical rotations and you're shown a 12-lead EKG in a patient and you're asked to interpret it, if you follow the steps I'm going to give you in this video, you should be able to make a reasonable interpretation of that tracing. And so the first thing I recommend you do when you're looking at an EKG for the first time is to look for the P waves and see if they are present. So P waves look like this. They come right before the QRS complex. And that's the first thing you want to do when you're looking at an EKG. It's the first thing I do as a cardiologist is I say, are there P waves present? You should be aware that normal P waves that are generated by the SA node, will be upright in leads 2, 3, and AVF. So if you look at this tracing on the screen here, you can see this P wave is upright, meaning it's pointing in this direction in lead 2. It's also upright in lead 3 and lead AVF. And so you want to make sure the P waves appear normal, that they're coming from the SA node. There are rare conditions where P waves are present, but they're generated from an aberrant focus somewhere in the right or left atrium. After you've looked for the P waves and decided whether they are present and normal, the next step I recommend you follow is to decide whether or not the rhythm is regular or irregular. And by that, I mean, what is the distance between the QRS complexes? This is called the RR interval. So if you look at this tracing at the top, this is a QRS complex and the next one comes here, and this is the distance between the two. We call this the RR interval. And if you look across the whole tracing, the RR intervals are the same every time. They're not changing. That is a regular rhythm. On the other hand, if you look at the bottom, this is an example of atrial fibrillation. You can see we've got a longer RR interval here. We've got a much shorter one here. And all the RR intervals are varying. Some are short, some are long, some are in between. This is an irregular rhythm. And so that's step 2 after looking for the P waves, is to decide whether the rhythm is regular or irregular. Once you've completed just the first 2 steps, you'll be able to identify 2 of the most common findings you're going to see on EKGs in your patients. So if P waves are present and the rhythm is regular, then most likely you're looking at sinus rhythm. There are rare other things it could be, like various forms of atrial tachycardia and atrial rhythms, but most likely when P waves are there and the rhythm is regular, you're looking at sinus rhythm. And so you can identify that just through the first 2 steps in this method I'm showing you. If there are no P waves present and it's an irregular rhythm, then you're most likely looking at an EKG showing atrial fibrillation. Atrial fibrillation classically has a rhythm that's irregularly irregular, and it's a very common arrhythmia. There are other things it can be. One thing that can mimic atrial fibrillation is atrial flutter with variable block, but this is relatively uncommon. And so once again, just by following steps 1 and 2, you should be able to identify sinus rhythm or atrial fibrillation, which are 2 of the most common EKG findings you're going to see. If P waves are present and it's an irregular rhythm, this is an uncommon finding, but if this is the case, then it could be some of these things listed here. These are relatively uncommon. One thing it could be a sinus rhythm with PACs. PACs are premature atrial contractions. We'll talk about those later in the video, but they're basically an extra beat that comes in early, and that can make sinus rhythm become irregular. There are also things like multifocal atrial tachycardia, which is an arrhythmia. You can also have sinus rhythm with various forms of AV block like Wenckebach, and these things will also give P waves being present and an irregular rhythm. If there are no P waves and it's a regular rhythm, then probably you're looking at some form of tachycardia. Many of these have hidden P waves, so-called retrograde P waves, that go backwards up through the atria to the SA node instead of from the SA node down towards the ventricles. So things like supraventricular tachycardia and ventricular tachycardia, some of this we'll talk about later in this video, but these things can give you an absence of P waves with a regular rhythm. After the first 2 steps, the next step I recommend you follow is to decide whether or not the QRS complex is wide or narrow. What I mean by this is a narrow QRS complex, which is a normal QRS complex, is less than 120 milliseconds in length, which is less than 3 small boxes on an EKG tracing. If you have a normal length narrow QRS, it means the His-Purkinje system is working and there are no bundle branch blocks present. On the other hand, if you have a wide QRS complex, more than 120 milliseconds, then most likely you have a bundle branch block. I'll show you some pictures of this in a minute. You also could have other uncommon things like a ventricular tachycardia, but in clinical practice, the most common reason you're going to see for a wide QRS complex is the presence of a bundle branch block. So just to make this very clear, at the top of the slide here is a normal narrow QRS complex. Note that it goes up and down very quickly. It ends before 3 small boxes in time or 120 milliseconds have passed. Down here at the bottom, we have a right bundle branch block, and hopefully you can see, even without measuring anything, just by looking at it, that this is a wide QRS complex. It takes a lot of time on the EKG for the QRS complex to complete. That's a wide QRS complex, a prolonged QRS interval, and on this example, you're seeing a right bundle branch block. Over here on the other side, we have a left bundle branch block, also with a widened QRS complex. So like I said, when the QRS interval is prolonged and the QRS complex is wide, you're most likely dealing with one of these two findings here, either a right or left bundle branch block. And I talk about bundle branch blocks in detail in another video, but just by way of review, the way you distinguish right from left is by looking at lead V1. A right bundle branch block will be pointing upward for the QRS complex. A left bundle branch block will be pointing downward. Okay, the next step is to check the other intervals besides the QRS interval. So you want to check the PR interval. A normal PR interval is less than 210 milliseconds, or about 5 small boxes or 1 big box in width. And the PR interval becomes prolonged in patients who have forms of AV block, which I talk about in another video. It also lengthens with patients who have high vagal tone, like athletes, and there are many drugs like beta blockers and calcium channel blockers that can prolong the PR interval. And then always remember, especially for step 1, that the PR interval shortens with sympathetic tone. So anytime the sympathetic nervous system is activated, either from stress or exercise, that will shorten the PR interval. And then you also want to look at the QT interval. I talk about this in the video on EKG basics, but this is the length of time from the start of the QRS complex to the end of the T wave. And it's hard to give you a number for a normal QT interval because it varies with heart rate. But a rule of thumb that's handy is the QT interval should be less than half the RR interval. So for example, if this is a QRS complex and this is the next QRS complex, the QT interval should end by the halfway point. So if you have a T wave that's going beyond the halfway point like this, that suggests a prolonged QT interval. And the QT interval prolongs with hypocalcemia, which can have symptoms like what I've shown here. It also prolongs with many antiarrhythmic drugs, and it's shortened by hypercalcemia, which can cause confusion and constipation like I've listed here. Okay, and then the final step of looking at an EKG by my method is to look at the ST segments. In many cases, you'll be shown an EKG in a patient where you're worried about ischemia, and your instincts are going to tell you to look at the ST segments first, but don't forget those first 4 steps, because if you simply focus on the ST segments, you often miss things that you would find if you went through the first 4 steps. But when you get to step 5 and you look at the ST segments, some of the things you want to look for are, first of all, T-wave abnormalities. I talk about all these things in other videos, but inverted T-waves can be seen with ischemia. Peak T-waves can be seen in early ischemia and hyperkalemia. And flattened T-waves or U-waves can be seen in hypokalemia. You also want to look for ST depression, which indicates subendocardial ischemia, and ST elevation, like what I've shown here, is what you see in transmural ischemia. Okay, so now let's just go through a couple examples of interpreting 12-lead EKGs using the 5-step method I just showed you. So this is an example of normal sinus rhythm. How do you know that? Well, I'm going to look at the P waves and see that they are present. There's one before every QRS complex in all the different leads. The P waves are upright in leads 2, 3, and AVF, so I know these are sinus P waves. And then the RR intervals, the distance between the QRS complexes, is the same over the course of the tracing. It's not changing. So I have normal P waves, normal RR intervals that aren't changing. And as I told you, this is almost always going to be normal sinus rhythm. If you go through the other steps, these QRS complexes are narrow and they are not prolonged. The PR interval here is normal if you measure it, and the QT interval is also normal, and you have no ST segment changes. Okay, here's a right bundle branch block. So once again, I'm going to start by looking for the P waves, and I see that they're present and they're upright in leads 2, 3, and AVF. So I have normal sinus P waves. Then I'm going to look at the RR intervals. The RR intervals are not changing, they're constant. So this is an example of normal sinus rhythm. Next, I look at the QRS complexes, and hopefully you can recognize that this is wider than normal, and it has that classic upward pattern in lead V1 that we see with right bundle branch block. After that, you can go look at other things. The PR interval is normal. These QT intervals are not prolonged. And there are some ST segment changes here. The T waves are upside down in V1, but that actually goes with the right bundle branch block. It doesn't indicate ischemia, but you do have some ST segment changes here. And then this is an example of a left bundle branch block. I won't go through all the steps, but P waves are present and the RR intervals are normal. So this is sinus rhythm. But then you've got a prolonged QRS interval here, and the QRS complex is pointing down in lead V1. That's how left bundle branch blocks look. And so this is an example of a typical left bundle branch block. Notice that you do actually have ST elevations here and T wave inversions here. And this is not something you need to know as a first or second year medical student, but those are normal findings in a left bundle branch block. Any patient who has a left bundle branch block is going to have some ST elevations in leads V1 through V3 and some flipped T waves in some of the leads. These do not indicate ischemia. Okay, so here's an example of atrial fibrillation, and the first thing you need to be able to recognize is that there are no definite P waves here. Now you do have a little bumpiness to the baseline, so maybe you might think, well, this is a P wave. But if that's a P wave, the exact same thing should be before the next QRS complex, and it's not there. The exact same thing should also be in other leads like lead 2 and lead 3, and you're not seeing it there. So anytime you just see one sort of lonely QRS complex that might have a bump before it that's a P wave, if you're not sure, look at all the other QRS complexes. There should be an easily identifiable P wave before every QRS complex if you're truly looking at sinus rhythm P waves. In this case, we just have a wavy baseline and there really are no P waves present. And so then we look at the RR intervals. And so here we've got one that's sort of medium in length. Over here, we've got one that's longer in length. Here we've got two that are pretty close together. So the RR intervals are varying. So we have an absence of P waves with varying RR intervals. This is an example of atrial fibrillation. Here's an example of atrial flutter. So atrial flutter will always have this sawtooth pattern present on the baseline between the QRS complexes. Notice that the sawtooth pattern is present in all the leads. It's pretty hard to find any lead that doesn't have the sawtooth pattern present. And that's important. In clinical practice, you will often see patients who have a bumpy baseline in lead V1 only, and you'll be inclined to think that's atrial flutter. But if it's truly atrial flutter, the sawtooth pattern is present in all the leads, no matter which one you're looking at. So we don't have definite P waves. We just have these sawtooth pattern things from atrial flutter. And then interestingly, in this EKG, the RR intervals are varying. That's because there is variable block. So sometimes the flutter waves generate a QRS complex with every 2 flutter waves. Sometimes it takes 4 flutter waves to generate a QRS complex. There's some degree of block in the AV node, causing variability to the RR intervals. This is an advanced EKG, not something a med student would be expected to recognize. The reason I'm showing it to you is because I just want you to recognize the classic sawtooth pattern. When you see that in all the leads, that's atrial flutter. Okay, and here's an example of ventricular tachycardia. You don't really need to be systematic to identify this. It's basically pattern recognition. It's really hard to tell where the QRS complexes even start and end, but I will tell you that this is probably the start of one and this is probably the end of one. And hopefully you can see that this is a wide QRS complex. It doesn't look anything like that normal narrow QRS complex we saw earlier. These QRS complexes are occurring very rapidly. They're about one big box apart, meaning the heart rate is about 300 beats per minute. So when you've got a wide complex tachycardia that's regular, this is probably ventricular tachycardia, although there are other things it could be. But for your purposes as a first or second year med student taking step 1, you just want to be able to recognize this from pattern recognition and know that it's ventricular tachycardia. That's all they're going to expect of you at your level. Torsade de Pointes, which is shown on this slide, is a subtype of ventricular tachycardia. What makes it unique from other forms of tachycardia is that the QRS complexes vary in height. They go from being very tall like this to being very short like this, and they sort of follow this wavy up and down pattern, and that's why it's called Torsade de Pointes. That means twisting of the points. And this is a subtype of ventricular tachycardia. And the thing to know about this arrhythmia, besides the fact that it's a life-threatening arrhythmia, is that it's associated with a prolonged QT interval. This is the feared outcome of a patient whose QT interval is prolonged. And so some of the things that can prolong the QT interval are shown here. Many antiarrhythmic drugs do this. There's something called the congenital long QT syndrome. There are a number of antibiotics that do it, like erythromycin and the quinolones, and many, many other drugs can prolong the QT intervals. And the reason this is always worrisome or bad when that happens is because this arrhythmia could develop. You can also get torsade de Pointes from hypokalemia, which can prolong the QT interval, also hypomagnesemia, and then rarely hypocalcemia. Even though hypocalcemia is a classic cause of a prolonged QT interval, it turns out, for reasons that are poorly understood, it rarely leads to torsades, whereas these electrolyte abnormalities more commonly do lead to torsades. And then I'll finish with this slide showing you a PAC and a PVC. So this is a PVC here. It's a premature ventricular contraction. So notice that you've got P wave followed by QRS, P wave, QRS, P wave, QRS, and then suddenly this wide complex aberrant beat comes in early. That's a PVC. PVCs will always have a wide QRS compared to normal. That's how you know it's a PVC. And it comes in early, and then there's a pause, and then you go back to having a normal rhythm. Down at the bottom is what a PAC looks like. So once again, you've got P wave QRS and everything appears normal. And then you get this beat that comes in early. Notice that it does have a P wave and it does have a narrow QRS. That's how you know it's a PAC and not a PVC. A PAC is a premature atrial contraction. So this P wave is being caused by depolarization somewhere in the atria. And that electrical activity is being conducted through the normal AV node into the ventricles, creating a normal narrow QRS complex. So PACs and PVCs, common findings in normal people. They also increase with stress and sympathetic nervous system activity. And if you're a first or second year med student, all you really need to know is how to recognize what one of these looks like. And that concludes our video on high yield EKGs.